Hello, my name is Sean McCafferty. I'm a practicing ophthalmologist from Tucson, Arizona at Arizona Eye Consultants. I have no present financial disclosures regarding this study. However, the study was financed approximately 7 years ago by Johnson & Johnson. Phacofluidics control has been the main thrust of phaco machine design over the past 15 years. When we talk about phacofluidics control, we are mainly left with our subjective opinion or controlled benchtop comparisons between different methods. The big question is, can we quantify fluidic control real time under general use conditions? The purpose of this study is to propose a method for evaluating multi-mode fluidics control under differing methodologies, active pressurization versus gravity pump assisted. The basics of fluidic control is relatively simple. Fluid in minus fluid out equals IOP, or what we perceive as fluctuations in IOP. All systems maintain fluid in by either bag pressure or bottle height. All systems modulate fluid out by altering peristaltic pump speed or venturi suction. It is a common misconception that active fluidic systems alter bag pressure in response to IOP fluctuation. It should be noted that we are discussing active feedback IOP control systems, but there are many passive dampening mechanisms which also contribute to fluidics control. We wanted to test two leading major phaco systems, gravity feed and active fluidics, as they are called. Test design included a single surgeon regularly using both systems, using a randomized contralateral eye design. Group A, one eye randomized to gravity feed system, and Group B, contralateral eye to the active fluidics control. We placed a standardized intracameral pressure transducer into the anterior chamber of 30 eyes in 15 patients undergoing sequential bilateral cataract surgery. We used single surgeon optimized surgical settings in each system in contralateral eyes. We recorded IOP at 25 Hz during all three modes of sculpt, quadrant, and IA, minus the variations during handpiece insertion and removal. Shown are the tracings of the data collected in contralateral eyes using the gravity feed and active fluidic systems in each mode of sculpt, quadrant, and IA. We enrolled 22 patients, of which 15 completed and 7 were not completed, mainly due to the difficulty of non-leaking pressure transducer placement in both eyes. Mode-specific phaco and IA times were not statistically different between the two systems. Average IOP across modes were not statistically different between the two systems. Since the anterior chamber fluctuations are mostly a sinusoidal variation from a mean IOP, we evaluated the root mean square from mean IOP to compare each modal and total IOP fluctuation. The active fluidic system significantly outperformed the gravity feed system in total, sculpt, and quadrant modes, but not in the IA mode. Independently, we examined large amplitude fluctuations greater than 10 millimeters of mercury and found the active fluidic system performed significantly better as well. In conclusion, we present a robust, quantifiable, and repeatable method for evaluating real-world phacosystem fluidics control. The active fluidic system, which I stated in the beginning is somewhat of a misnomer, generally outperformed the gravity feed system, with the exception of IA. It was noted that maintenance of a high mean intraocular pressure dampens fluctuation in IOP, and that recent phaco machine design trends toward lowering this mean IOP, which will exacerbate the anterior chamber IOP fluctuation problem. At the present time, no system is able to provide more than 1 to 2 Hz of feedback loop IOP control, and the reason is the distance between the IOP sensor and the IOP actuator from the eye is approximately 1 meter. The solution is gaining up to 20 Hz of fluidics control is to shorten the distance down to 0 to 30 millimeters. We present a method of a handpiece bypass fluidics design called Phacoemulsification fluidic control using hydraulic oscillation modeling in a separate video.